Welcome. In this lecture, we'll be discussing movement disorders. We'll be exploring these 5 key movement disorders in detail. Let's begin with the first, Parkinson's disease. Parkinson's disease is caused by the progressive degeneration of dopaminergic neurons in the substantia nigra pars compacta, leading to decreased dopamine in the nigrostriatal pathway. This results in an imbalance between dopamine and acetylcholine in the basal ganglia, impairing the motor circuit. If you remember back to the early days of medical school, you probably learned the importance of basal ganglia in controlling movement. It does this via the direct and indirect pathway. Now, these pathways, seen down here in this image, are not something you need to know for step 2 or for step 3, but it is important to know their usual or normal function, as well as how these functions change in individuals with Parkinson's disease. Normally, the direct pathway in the basal ganglia facilitates movement by stimulating the motor cortex. Dopamine enhances this pathway via D1 receptors, promoting voluntary motion. The indirect pathway, on the other hand, inhibits movement by suppressing the motor cortex, and dopamine normally inhibits this pathway via D2 receptors. But in Parkinson's disease, since we have a loss of dopamine, this leads to a reduced activity of the direct pathway, meaning that less movement can be initiated, and an increased activity of the indirect pathway, meaning that more movement is suppressed. This results of the classic symptoms seen in Parkinson's disease, such as rigidity and bradykinesia. Thus, it's important to know that the low dopamine is associated with issues initiating movement. This is important when we talk about symptoms as well as treatment for Parkinson's disease. The last high yield point is to know that Parkinson's disease classically affects the nigrostriatal pathway. A mnemonic that I use to help remind myself of this is with the words, the nigrostriatal is not stable. It rhymes and it helps to put these two together to help remind myself. Now, the presentation of Parkinson's disease is classically seen in older individuals, typically in the ages around 70 to 79 years of age. Please note that there is an increased risk factor with the use of synthetic heroin, specifically MPTP. The reason being is because MPTP is metabolized to MPP+, which can actually destroy the substantia nigra and cause Parkinsonian-like symptoms. Now, Parkinson's disease is a movement disorder. It classically does not affect memory early on in the course. It can cause dementia, but this is by definition greater than 1 year after the symptoms of Parkinson's first are found. And that 1 year cutoff is extremely important. The symptoms are secondary to the low dopamine. Remember, low dopamine means that we have issues with movement. We can see bradykinesia, issues with initiating movement or slow movements. Resting tremor, typically worst at rest, better with movement, and classically described as pill rolling. Imagine there was a pill between this individual's 2 fingers and they were rolling that pill back and forth. That is classic for Parkinson's disease. You may also see a hypokinetic, aka shuffling gait. In these individuals, they are typically stooped forward. So they're leaning forward, maybe stooped, and they have these very small steps that look like they are shuffling their feet along the floor. This can become very severe, and then this leads to postural instability, which increases the risk for fall. But this is classically a late finding. And then, of course, you may also have rigidity. Again, all of this is secondary to the low dopamine. You may also have associated with REM sleep disorders. This can either be nightmares or dream enactment. In question stems, this may be given to you as the significant other during sleep may notice that their partner is reaching their hands out in front of them or kicking their feet. They may be reenacting their dreams. A mnemonic to help remind you of this classic presentation is that Parkinson's traps the body, where the T stands for tremor, specifically resting, R for rigidity, A for akinesia or bradykinesia. Akinesia means no movement, bradykinesia means decreased movement. Postural instability is the P, and then S is for shuffling gait. Now, there are some high-yield clinical correlates to note with Parkinson's disease as well. It is highly associated with something known as seborrheic dermatitis, which is seen here in this image. This will typically be yellow, greasy scales with erythematous or red base, plaques, and this classically affects the face, more so where hair is located, so the scalp, the eyebrows, the eyelids, or the ears. Treatment is typically emollients or shampoos, and if this does not work, we may treat with topical antifungals. Aspiration pneumonia is also a high-yield clinical correlate, and this is thought to be secondary to swallowing dysfunction. Remember, Parkinson's disease is a motor issue. Later in the course, you may affect your esophageal muscles or even just your mouth muscles. This will typically be a pneumonia located at either the right lower lobe or right medial lobe. This is classic for aspiration pneumonia, as typically what occurs is that the bronchi is more superior on the right side and much, much more vertical. So it's easier for something to get lodged in there and leads to pneumonia. Individuals with aspiration pneumonia with Parkinson's disease will need a swallow study. And if they fail this, then we typically put them on thickened liquids or change their diet around. Treatment of aspiration pneumonia is typically with ceftriaxone and azithromycin, or even sometimes clindamycin. Now, Parkinson's disease by definition is diagnosed clinically, but please note that for the purposes of exams, bradykinesia is part of the definition of Parkinson's disease diagnosis, and it must be present in the question stem in order for it to be Parkinson's disease. Now, Parkinson's disease is secondary to low dopamine. Thus, the treatment in Parkinson's disease is going to be to increase dopamine. There is a gold standard medication, and that is known as carbidopa levodopa, and they work side by side to help increase the amount of dopamine in the central nervous system. Classically, dopamine cannot cross the blood-brain barrier, but levodopa can. Thus, levodopa can cross the blood-brain barrier, then become dopamine, and help to improve movement. It does this with the help of carbidopa, as carbidopa prevents peripheral conversions of levodopa into dopamine. Thus, it increases the amount of levodopa that can cross the blood-brain barrier and increases the amount of dopamine in the central nervous system. This is your gold standard. This is almost always a first-line medication in individuals, especially older individuals above the age of 70 with Parkinson's disease. In some other individuals, we may want to treat them with dopamine agonists. This can be bromocriptine, ropinirole, pramiprazole. Amantadine also increases dopamine levels, but it is not considered a dopamine agonist. I've just included it here because it has a very similar risk factor. The biggest side effect of this will be psychosis. So typically visual or auditory hallucinations, they're seeing things that are not there. Now, with dopamine agonists, in Parkinson's disease, we can treat this either one of two ways. We can either lower the dose of one of these above medications, or we can add on an antipsychotic. Almost always, we try to lower the dose, obviously, if able to, of the above medications. The reason being is we don't want to just add on another medication and induce more polypharmacy into this individual, especially an individual that's at increased risk for aspiration pneumonia if they have Parkinson's disease. Now, when the patient is maxed out on these prior medications and they're still having symptoms, we can add on other medications. This can be MAO-B inhibitors. All of these prevent degradation of dopamine. This ends in G-I-L-I-N-E, so Gilene, so Silagilene, Razagiline. And of course, you can also try the COMT inhibitors, and these are add-ons again. This prevents degradation of dopamine, so all of these are decreasing dopamine breakdown. Or simply put, they are increasing dopamine in the body. And this will be reminded yourself with the capones they end with, tolcapone, entacapone. As a last resort, when they're maxed out on their medications, we can't add anymore and they're still having symptoms. Let's say they're still falling or something along those lines. We can try a deep brain stimulator. This is usually placed in the globus pallidus, the thalamus, or the subthalamic nuclei, and it will actually function on those direct and indirect pathways directly that we were talking about. Now, for Parkinson's disease, there are something known as Parkinson Plus Syndromes, which are high yield to know for your exams. These syndromes present as Parkinson's, but they have a next or an extra symptom that kind of separates it from Parkinson's. So the three syndromes, the first one will be multiple system atrophy, also known as MSA. This will have all the symptoms of Parkinson's, but they will have early onset dysautonomia. Please note that late stage Parkinson's, like normal stage Parkinson's, can have late dysautonomia, but one of the first symptoms of multiple system atrophy is dysautonomia, such as orthostatic hypotension or erectile dysfunction. It is also highly associated with anticolus. Roughly 25% of people have this, in which you have forward flexion of the neck, demonstrating this image here. The average age of onset of MSA is very, very early. It is around 50. Progressive supranuclear palsy will also have all the symptoms here of Parkinson's, but they will also have this vertical gaze palsy. Typically, an individual will be stuck in this downward gaze. They might also have retocollis, and an individual will lead to extension of the neck. The way that I have always liked to remember this with progressive supranuclear palsy is if my eyes are stuck downwards and I want to look ahead of me, I have to extend my head backwards in order to see in front of me. And that's why I always remember that this is associated with retrocolus. The average age of presentation is more close to typical Parkinson's, around the age of 65. And then the lowest yield one is something known as corticobulbar degeneration. This will be an asymmetric movement disorder, in which Parkinson's is thought to be a symmetric movement disorder. So this may also only affect the right hand and the left leg or something along those lines. And this is classically associated with astrogenesis, in which an individual cannot recognize objects in their own hands. The next disease we'll talk about is Huntington's disease. Huntington's disease is an autosomal dominant neurodegenerative disorder caused by CAG trinucleotide repeat expansion. And this is classically seen in the HTT gene. It is thought that the CAG repeats is worse as throughout the generations, so father to son to grandson. And these CAG repeats increase with each generation, and this leads to anticipation, meaning that as each generation gets worse and worse, or you get more and more expansion, the presentation of Huntington's disease will actually be earlier and earlier. This is classically associated in chromosome 4, and what is typically affected in Huntington's disease will be the death of the caudate and the putamen. And this is typically done by something known as glutamate excitotoxicity, just overactivation of all these nuclei, or of these two nuclei, will actually lead to its death. And this leads to changes in neurotransmitters. So classically, we have a decrease in two, GABA and acetylcholine, but we also have an increase in dopamine. Remember, we know that a decrease in dopamine leads to issues with the initiation of movement. But an increase in dopamine is going to be the opposite. It's going to lead to more movement, or abnormal movement, involuntary movement that we cannot control. Thus, the classic presentation of Huntington's disease will have a usual triad. This triad will usually be these involuntary movements due to the increased dopamine. Typically, you might see chorea. This will be like these dance-like hyperkinetic movements. If you have your hand down to your side or your arm down to your side, and just think about it all of a sudden just kind of like reaching out in front of you, like trying to grab something that's not there. That's very choreic-like. Sometimes they might like wring their hands, and that's also chorea-like. It's called like wing tremor. You may also see tics, ataxia, or falls due to these involuntary movements, and you may also have delayed eye saccades. Huntington's disease will also cause very, very, very early onset dementia. Typically, again, with anticipation, it varies, but in individuals around the ages of 40 years of age. And then, of course, psychiatric dysfunction is also highly associated. Typically, we have depression. These individuals are very, very high risk for suicide. One of the most common causes of death in Huntington's disease is sadly suicide. And this can also cause psychosis, sleep disturbances, hyper or hyposexuality. The diagnosis of Huntington's disease is gold standard with genetic testing, in which you see these CAG repeats. In some cases, imaging can help support the diagnosis as well. In the MRI of the brain, we have an atrophy of the caudate of the putamen, which we've already talked about, but you may also see these enlarged lateral ventricles, and this is due to all this brain atrophy. If you see out here, all of this is just dead tissues, all atrophy, and this causes enlargement of these ventricles, and it's classically the lateral ventricles. The treatment of Huntington's disease is going to be with VMAT2 inhibitors, risperidone, or tetrabenazine. And of course, you can also give dopamine inhibitors. Remember, this is associated with high amounts of dopamine. Thus, medications, specifically Haldol, will lower the amount of dopamine and thought to improve symptoms. Otherwise, most of the treatment is supportive, as there is no cure for Huntington's disease. After being diagnosed or its symptoms begin, you have roughly 20-year life expectancy. The next pathology we'll talk about will be essential tremor. This is highly associated with family history of tremor. The average age of onset is between the ages of 35 to 45, so relatively young, and the overall pathology is not known, but it is known to be autosomal dominant and associated with family history. Presentation is typically going to be bilateral hands or the head. Sometimes it can even affect the larynx, which can cause vocal issues. This is classically worsens with stress and movement. This is compared to Parkinson's, which is usually better with movement and worse at rest. Essential tremor is typically better at rest and worse with movement, so it's the opposite. And this is also thought to be better with alcohol usage as well. So be aware of individuals abusing alcohol with essential tremor to treat this medication, to treat this pathology, and always be aware of withdrawal symptoms as well when you put them on appropriate medication. The diagnosis is completely clinical based on what we've just talked about. And then the treatment is typically, these are first-line medications, propranolol or primidone. They are both equivocal to one another. The only time that primidone may be the better option is if an individual has a history of asthma, as propranolol is contraindicated in asthmatics. Now, other tremors that we will talk about briefly will be intention tremor. This is a tremor that worsens as the patient approaches a target. Classically, if you do the finger, nose, finger, you may see as the patient is approaching your finger as the physician, their tremor might start to worsen. This is thought to be caused by cerebellar issues, so classically seen in MS, strokes, tumors, or traumas. And this can lead to other cerebellar signs too, such as ataxia, troubles with balance. Nystagmus is classic, so central nystagmus, in which we've gone over in another lecture with vertigo, as well as dysarthria. And then, of course, you have physiologic tremor, which is a normal tremor. This is typically described as low amplitude, so not very, very easily seen, with a high frequency. So it's going back and forth very rapidly, but it's not very, very noticeable. Typically, it's unnoticeable. The only time that this typically comes out is during times of stress or anxiety. Sometimes caffeine can also make it worse. An example being if your hands were ever shaking, if you're ever in the OR and you're performing a surgery, trying to cut something open, or you're a med student and they're asking you to do a suture, you might notice that your hands are beginning to shake. And this is known as a physiologic tremor. And as always, here's a table summarizing what we've talked about in this lecture. And that concludes this lecture on movement disorders.